Hi, I'm Mahmoud Nassar. I'm a consultant ophthalmologist. Today I'm going to talk about adult squints, which is one of my main subspecialties. Um, Adult squint can be also named as a lazy eye, as strabismus, which is the more scientific name. Basically, it is one eye drifting away from the other eye. So both eyes there's an angle between the two eyes. Um, 9 out of 10 patients know that their eye is drifting, but there is a small percentage where they don't know that the eye is drifting, and people tend to point it out. Um, from an adult point of view, people tend to present either with the eye that's been drifting for some time. It usually starts on off and then becomes more constant and then becomes more of a social problem at work. Or some of the acute presentations can be presenting as double vision, where you see two of one image. And at that point, things might be of a serious turn and need more urgent investigations. The concept of squint is basically a misalignment between the two eyes. So one eye is pointing in one direction, which is taking up fixation, and the other eye is drifting. That drift can be outwards, inwards towards the nose, upwards, downwards, and there's also a rotational squint where the eye is rotating to one side. Obviously, how we work out what happens in clinic starts with my examination and history taking, which is kind of like detective work. So we start with how it presented, how long has it been there, anything related to general health, any additional neurological signs, and we take it from there, because that part is extremely important because it narrows down the very, very wide differential of a cause of an eye to drift. After that assessment, obviously a full eye examination, how the eye is working, would be done in clinic, but an extra appointment will be needed for an orthoptic assessment. That orthoptic assessment is mainly specialist that does eye movement. They check how each eye is working individually and how both eyes are working together as one unit. And they also document the angle between the two eyes accurately in prism diopters. Following the orthoptic assessment, there will be a follow-up in clinic. During that, we tailor down what the problem is, any further investigation needed, and a management plan. If the presenting issue is double vision, usually triggering of investigation would start in the first assessment, but treating double vision can involve either a patch, prism, or squint surgery, which we'll come on to later. If the presentation is only an eye drift without double vision, 9 out of 10 of management will be squint surgery. The surgery is done as a day case. It's done under a general anesthetic, where the patient is put to sleep during the procedure. Most of my cases I do with a technique called adjustable suture technique, which reduces the risk of over or under correction after surgery. What that name means, adjustable suture, means that 90% of the procedure is done when you're asleep under an anesthetic, and I leave the muscle on a secure bow tie, which is secure in place. If there's any immediate issues rising from surgery that needs to be addressed, will be done there and then under local anesthetic. That is to guarantee the best surgical outcome, especially from a double vision point of view or from an eye position point of view. Squint surgery itself is based on the angle of squint. So depending on the angle between the two eyes, the decision of surgery is made. And obviously along with that, if previous squint surgery was done. So basically, it mainly involves either weakening or tightening of eye muscles to reposition the eye muscle in alignment with the other one, so both eyes are working as one unit. Other treatment options, as we've mentioned, include patching, prisms, and there's also the option of Botox injection, which works as a diagnostic and as a therapeutic procedure. We use it sometimes just to know how the whole visual system is built and what happens if the eyes are fully aligned before we commit to surgery.